Working out where we are with the reproduction rate of the virus, its ability to spread, is a key part of decision-making on lockdowns and something that we're looking at throughout the programme this morning. The Harvard professor Mark Lipsitch is one of America's leading epidemiologists, director of the Centre for Communicable Disease Dynamics at the university's School of Public Health. I asked him what information was needed.
The main thing is that we need two indicators which are closely related. One is sort of the level of cases that we're at as a daily number. And the other is the rate of change, which is either an increase or a decrease, and is related to the R, which is 1 when it's flat and bigger than 1 when it's when it's growing, and less than 1 when it's shrinking. And the reason they're both important is that what we're trying to do as we ease is have a sustainable level of cases where we're not reaching, again, the point where the healthcare system would be threatened. And to do that, we need to know not only where we are, but how fast we're moving, in which direction. So those are the two key indicators, and exactly what level of each one is acceptable depends a little bit on how much spare capacity you have, how big a jurisdiction we're talking about.
But how can you establish those two numbers, or particularly the first one, the level of cases, without regular random testing in the population as a whole?
Well, you can't to get an absolute number, and that's one of the many challenges in this. But I think with a relatively fixed level of testing, it's still possible to get an idea of the relative number and sort of how that relates to the hospital capacity. But it's a challenge because the sides of the whole iceberg is the unknown. But the relative number is still a meaningful quantity.
If you're in the position which England is in now, people have been encouraged to go back to work if they can't work at home, and then you see the number of cases edging up or changing slightly, how difficult is it to then model how it might spread from that point?
I think one of the challenges for modeling is knowing exactly what each intervention individually and together does, because we've never had social contact patterns like the ones we have now. It's just sort of unknown territory. We can make hypotheses, but also this is a new virus, so how it transmits is not fully understood, and the role of children and those sorts of things. Models are tools for turning facts plus assumptions into scenarios and predictions, but we can't predict how governments are going to behave. That's not the job of infectious disease modelers. We have to make certain assumptions, and we also have to make some assumptions that are not fully factual about the behavior of the virus, because that's an evolving scientific field. When we make these projections, they are assuming explicitly that certain things are true, which we know may change as time goes on. So the biggest inconsistencies between models have been models that assume effective government response versus models that assume ineffective government response and have much greater tolls. And those have been misused to suggest that models don't get it right. But if a model said the same thing under two different scenarios, you would know it was wrong because it wasn't taking into account the relevant facts.
So you're saying that because you think that the modelers might end up getting blamed for the handling of pandemics going wrong and the numbers of cases and deaths being higher than people had expected or hoped for?
I think it's already happening. I've heard that it's happening in the UK. It certainly happened in New York State. The models are translations of what we currently know and what we currently think we know into scenarios for how the virus epidemic might unfold. But the models can't create scientific knowledge about facts outside the model. They have to use what we currently know. And to be frank, I think even with any of the current knowledge we have, the fact remains that the size of the epidemic unchecked would be catastrophic, both for the healthcare system and in terms of total casualties. So those models have stimulated policies that have saved lives.
And on the vaccine development, clearly a large number of candidate vaccines around the world. Do you think that the time frame of 12 to 18 months is too optimistic?
There is a non-zero chance that we just won't be able to make a vaccine. We have tried coronavirus vaccines in the past and not succeeded so far. I think the more likely scenario is that there will be some of these candidates that work reasonably well. And then I think 12 to 18 months to have a good number of vaccines for hundreds of millions of people is realistic. I think for 7 billion people is optimistic unless we have some kind of really remarkable scale up of manufacturing capacity.
But you've written about speeding up the approval of vaccines through controlled human challenge studies, essentially deliberately exposing human volunteers to the virus. Do you still believe that is a way ahead?
I think that needs to be an option for our trials. I don't know if it will be needed or not, but it's essential that we prepare for that, which is a relatively low-cost activity and doesn't in itself create any risk to anyone. If there are situations where we have a vaccine that looks promising and not a place where it's easy to test in a very high incidence setting, then human challenge trials are a really important alternative way. And I've heard Adrian Hill, for example, worrying that the Oxford vaccine will be hard to test because there won't be enough disease incidence by the time that the test is ready to go.
And you would take previously uninfected people with a low risk of complications or mortality, so essentially younger people, to be part of a study like that.
That's right. Yep.
Would the results of it tell you anything about how the vaccine would protect people who were older or infirm?
Alongside the challenge trial, there would be a larger study of thousands of people, including different age groups, where they just get the vaccine and we don't wait to find out if they get infected or not, but we measure their immune responses and check for safety problems. So that would be a way of potentially bridging from the younger to the older. But it's also important to say that if we could immunize large fractions of the population that are at low risk themselves, but who we want to protect against becoming vectors to older or more at-risk people, that would help to reopen society tremendously.
Finally, Professor Lipsitch, what about the political handling of all of this, and particularly in your own country? As an epidemiologist, when you see President Trump in his White House briefings on this, what do you think?
Those briefings, the parts that he dominates, which is most of them, are not science-based. They're fantasy and off-the-cuff remarks about things like his statement recently that this thing is going to go away without a vaccine. I mean, it's unjustified, unscientific, and undignified, in my opinion, and very sad to watch, having seen our government respond very effectively on the national and international scale to previous epidemics and pandemics.
But he has scientists advising him. He has scientists often on the stage with him.
He does, and I admire them tremendously for the job they're trying to do, but they can only do so much because he's the boss.
Professor Mark Lipsitch, thank you very much.
Thank you.